Welcome, everyone, to the May 7th Addiction Toxicology Case Conference. This is brought to you by the American College of Medical Toxicology and the American Society of Addiction Medicine. I want to direct you all to prior Addiction Toxicology Case Conference webinar series FAQs. These were produced during a series supported by the Opioid Response Network, as well as ACMT and ASAM, and include some outstanding information from those presentations. I'm Dr. Tim Wiegand, Director of Addiction Toxicology and Associate Professor of Emergency Medicine at the University of Rochester Medical Center. And my co-moderator is Dr. Gloria Bishevitz, Medical Director of Strong Recovery and Professor of Clinical Psychiatry at the University of Rochester Medical Center. We also have Dr. Alexandra Amaducci, a fellow in the emergency medicine and emergency medicine physician at the Lehigh Valley Health Network, Bethlehem, Pennsylvania Medical Toxicology Fellowship. Dr. John Hopper, ASAM expert. He is faculty at and clinical professor at Wayne State University School of Medicine and clinical professor at Central Michigan University, Mount Pleasant, Michigan. And he works at the recovery as a recovery medicine physician in the Integrated Health Associates, Ann Arbor, Michigan. And Daniel Sessions, Dr. Sessions is a medical toxicologist and addiction medicine physician, as well as emergency medicine physician who works at Emergency Care Consultants and for the Minnesota Poison Control Systems in Minneapolis, Minnesota. No conflicts of interest to disclose for today. We have some learning objectives. We're focusing on beyond the fentanyls, other novel synthetic opioids. We really, when you think of synthetic opioids, you think of fentanyls and the fentanyls analogs, but there's other synthetic opioids out there. So our objectives are to review the pharmacology of the novel synthetic opioid MT45 and the signs and symptoms of intoxication and overdose from MT45. We'll also review the pharmacology and abuse potential of tianeptine and discuss the treatment of tianeptine dependence and withdrawal, and describe other non-fentanyl-based novel synthetic opioids appearing on the illicit drug market and new adulterants reported with NSOs and heroin. Case 1, MT45 overdose with tinnitus and hearing loss. A 24-year-old male reports hearing loss and tinnitus after he is awoken from overdose from EMS-administered naloxone after using a research chemical he had ordered from the internet called MT45. So he's brought in bluish to the ED after a roommate called 911 reported that he found him unresponsive, barely breathing, and bluish. EMS had arrived, found him comatose with marked bradypnea, and they give him IM naloxone and support him with a Babe valve mask ventilation. As the medics oxygenate and ventilate, the individual's color improves and he starts to breathe at a better rate. Within 3 to 4 minutes, the patient's opening his eyes, but is yelling loudly to the medics, "What happened? What happened?" and described as shaking his head and not seeming to understand instructions. He seems confused, yet he's yelling clearly what happened. During the transport, it is clear the patient has hearing loss, although he can hear if providers yell loudly into his ears, either ear, both ears, and he reports ringing. And he says, "This has never happened previously." And this is a rather dramatic interaction. This is not a simple conversation. He does not have recurrence of sedation. He does report insufflation of approximately 150 milligrams of MT45, a research chemical he bought online and had delivered that day on recommendations from friends. So my questions to the panelists are, what is MT45? And what signs and symptoms are seen in an MT45 intoxication or overdose? And is the hearing loss common? Is this consistent with MT45? And I'll start with Dr. Amaducci. What do you think?
Sure. Good morning, everyone. Thanks for having me. So MT45 is one of the novel synthetic opioids, and it is similar to morphine in structure, but it's a phenanthrene-based structure. And so being that it's a synthesized chemical and it kind of has a similar structure to some of the other novel opioids that we've seen, like U47700. And so you would expect a typical opioid toxidrome like you describe, but it seems like it has some more significant ototoxic effects than just your typical opioid. You know, we know that we can see some hearing changes when patients have an opioid overdose. Usually it's acutely. I know that there have been some instances of chronic opioid use having some hearing issues, but this seems to be much more significantly ototoxic. So that's why I think that, you know, kind of honing in on this hearing loss is an important clue that this may not just be your typical opioid overdose.
And have you seen response to naloxone typically if a patient is overdosed with MT45?
So I think that I haven't actually seen an MT45 overdose. From what I've read, it seems like, you know, the respiratory effects are reversed easily with the naloxone, but the hearing changes can be a little bit more persistent.
Okay, thank you. Dr. Hopper, what are your thoughts?
Yeah, I have not seen it either, but I think the ototoxicity is interesting in the setting of this. It sort of might give us some clues as to what ultimately is the potential ototoxicity of opioids in general. There's some thoughts they may have direct toxicity in the cochlea. Certainly patients with heroin occasionally have had transient hearing loss, and it would be interesting in situations like that to wonder whether there are other novel synthetic opioids in the setting of heroin use.
Yes, thank you. Dr. Sessions, do you have any thoughts or comments?
Yeah, I mean, I think when we were seeing more heroin and hydrocodone overdoses in the past relative to fentanyl and oxycodone, I feel like, you know, we definitely saw a lot more ototoxicity. And I don't know if that's something to do with the structure of heroin or hydrocodone, but those seem to be the two big players. You know, as I kind of read more about MT45 and I did what I normally do when there's a novel psychoactive substance, I went to Arrowhead and kind of looked at some of the user experiences, because a lot of those people have experiences with other, not just the more typical opioids, but the novel ones. And it, you know, it seems like what happened is that there was such a slow onset and such a prominence of the other side effects, like the itchiness, the skin stuff. It seems like, I don't know if this is a dose-related phenomenon, because people felt like they were having such a prolonged onset to their buzz that they were using higher and higher doses. They were using them intrarectally. They were using them in combination with other things. So that was kind of a thought that I had, that maybe it was just due to the large dose that we were seeing kind of these weird skin and hair and ototoxicity side effects.
That's interesting. You bring up a great website, the arrowhead.org, a nonprofit, which is quite useful for understanding, you know, any common psychoactive chemicals, drugs, plants, intoxicants. www.arrowhead.org, I believe, is the website for that, which I too usually go to Arrowhead or Blue Light, which is a forum if I'm interested in what the user experience or what people are talking about. So if you're listening to us, you can send us questions or comments in the Q&A. Dr. Bashevitz is moderating that. But Dr. Bashevitz, have you taken care of anyone that's reported MT45 use, or is any Q&A comments particularly pertinent here?
No, I haven't been able to see a case. And Dr. Hopper has volunteered to answer one of the Q&A comments.
Great. We can read one. Go ahead, Dr. Hopper.
Yeah, actually, I appreciate Dr. Sessions' comments on Arrowhead. And it is interesting that when in my review of Arrowhead, there are relatively few mentions of it in terms of psychoactive use, dating back to around 2014. And that's the time that there was a case series in Sweden that was published as well. Although this is a very old drug, goes back to the 70s. In terms of ototoxicity, really not well understood, but it is postulated that there could be direct toxicity to cochlear nerve cells, has been the hypothesized mechanism of ototoxicity.
Yeah, MT45 was synthesized in the 70s by a Japanese pharmaceutical company. They were looking for a series of opioid analgesics, and so there are a number of these. They're piperazine-based opioids, but MT45 really was the most common and is really a unique opioid. Dr. Sessions mentioned this kind of slow onset, and I saw that as well. This was a single use from what the patient had reported to me, but I saw reports that people would get in trouble redosing as the onset of the effects was a little bit slower. It can be administered intravenously with a fairly quick onset, has about 80% of the potency of morphine. So 150 milligram dose is a fairly high dose. We don't have history of what tolerance this gentleman has. Moving on to the chemical structure. So the classic opiates and semi-synthetic opioids really have this phenanthrene backbone. So opiates from the poppy, you can see this phenanthrene backbone buried in morphine to the right, and they work with the mu receptor as well as other opioid receptors. Some of the non-fentanyl novel synthetic opioids really don't have that as the classic structure. We're familiar with U47700. This was sometimes referred to as pink because it had, during synthesis, a pinkish residue typically left as it was produced, and it was one of the synthetic opioids identified in the adulterated pills that had been involved in the death of Prince, certain outbreaks of U47700. And this is a benzamide-based opioid. There's several benzamide-based opioids, U48800, U50488. That's an acetamide-based opioid, so just a little bit different chemical structure. U51754, methylacetamide, and then AH7921, another benzamide. AH7921 was pretty popular a few years ago. And then we have the piperazine-based opioids, the MT45 to the right bottom, and cousin, although this I have not seen reported, this 8121, but it is a piperazine-based opioid. Piperazines were popular as most of them have serotonergic activity, and for a period of time in the 90s, early 2000s, I believe, were replaced MDMA as the chemical in ecstasy sold as MDMA, ecstasy in the electronic dance scene or recreational drug markets, and even in the legal high markets in Europe, really before that was clamped down. You can still buy this online. This is a chemical supply site just through Google and not the dark web. You can see from $65 to $195, and the suppliers are all through Chinese supply companies. There's a number of them that are offering this, and this is just the first tip that I had as I Googled this. As I mentioned, the potency is similar to morphine, although it's thought to be about 80%. And case reports include sedation, respiratory depression, and several with sensory narrow hearing loss. This also is referred to as opiate-associated hearing loss, or OAHL. There was a case series published from the Sweden Strida project that Dr. Hopper mentioned that looked at a brief period from November 2013 to February 2014 and identified 9 cases from ED and hospital visits where MT45 was detected in the urine or blood. And 4 of these 9 patients had MT45 only. They described opioid-like effects and positive reversal with naloxone. And it was interesting that 3 of these 9 patients had sensory narrow hearing loss, and 1 of them had persistent symptoms at 2 weeks. And sensory narrow hearing loss is bilateral hearing loss with tinnitus. And it's an interesting case series, certainly greater hearing loss than I've seen. So we've talked a little bit about this, but as I looked at the literature, it seemed that this has been reported not just with opioids, but also cocaine, occasionally stimulants, other drugs, and I'm wondering if other panelists have experience with patients that have reported this. Dr. Bashevitz, have you had patients report hearing loss either after overdose or use with opioids?
Well, I haven't. I know it occurs, but the time I did see hearing loss, it was with indomethacin, actually, a patient taking indomethacin.
Right, there's ototoxic, other drugs with ototoxicity, but Dr. Amaduchi?
Yeah, the one that comes to mind is we had a 15-year-old who overdosed on her father's methadone. And she, I think, didn't realize that she was having hearing issues, but similar to the case, kind of had repetitive questioning, said that we sounded muffled or funny, and she had some hearing loss because of that. But that resolved over the course of a few days.
Yeah, I've seen this with a number of opioids, from methadone. I have seen with fentanyl. And from what Dr. Sessions had said, I agree. In the literature, it seems hydrocodone and heroin probably the most common. There have been some series published from Poison Center data that describe the frequency. I don't have that data included, but if anyone's interested, there is data out there that describes this opioid-associated hearing loss as well. Dr. Hopper, do you have anything to mention? You mentioned this is thought to be a cochlear, vestibular effect from the drugs, but do you have any other thoughts or comments?
My only other comment is in the literature, at the times when I've seen it, in addition to heroin, I haven't personally seen oxycodone cases, but that has been reported as well. But certainly the indomethacin is an interesting one as well. With heroin, of course, you never know exactly what you're getting in the heroin supply, but I do recall some oxycodone cases.
Yeah, there's some interesting adulterants that we can talk about later, but there are things like quinine, that may also have effects. But Dr. Sessions, anything to add to this?
Yeah, I would just say one that it's definitely when you sort of peruse the literature, there's a lot with just chronic use, not just acute overdose. And we've kind of referenced all the various ones that seem to be mostly implicated. And then there's some I think rodent data, at least, that suggests the combination of hydrocodone or hydromorphone and acetaminophen is a little more cochlear toxic. But I don't know that that's borne out in the human experience.
In my experience, as well as from looking at the literature, this is transient, but has been in some cases permanent. That is uncommon, but usually has a improvement over the course of hours to days, typically, but can persist for a longer duration.
I have some comment from the Q&A section. One question is, how do you identify this MT45? Is there a urine or blood test for it?
One could send it out to a forensic lab. NMS labs can test for MT45. It's certainly not going to be a chemical that will trigger the opiate screen or, from what I understand, have any cross-reactivity with the standard urine drug screen. So this would be a send out. If it's during the intoxication, you would send out blood or serum plasma and urine as well. You could identify it from, but there are a number of reference labs that would offer MT45 as analytes. This case was identified. He self-reported and had a supply of the substance as well, so it was very forthcoming. So I have a couple final comments. MT45, 80% potency morphine, and reports of oral, intranasal, IV, and also, as Dr. Session mentioned, rectal. There is a fluorinated analog of MT45 that has recently appeared on the recreational markets. And what do panelists think about how the fluorination or addition of fluorine to other substances is not uncommon? We have fluelprazolam as one of the most common synthetic benzodiazepines in our area. How will that affect, do you think, at least hypothesize, an MT45 intoxication or even the pharmacology? Dr. Sessions, any thoughts on that?
I wonder if it just may increase, if it's an attempt to work around that slow onset, increase solubility and kind of increase that earlier peak effect, and maybe give people an earlier onset of their intended intoxication.
Yeah, that's typically what I anticipate is the fluorine will increase the potency slightly as well as the lipophilicity. And so cross the blood-brain barrier more rapidly and onset of effects a little quicker. So, and then you've mentioned some chronic symptoms from MT45 use, and you described a few of those. Any other panelists aware of the chronic toxicity from MT45 that has been reported?
I think
Dr. Hopper?
mentioned,
Or go ahead.
oh, I'm sorry. I think Dr. Sessions mentioned earlier that there's some pretty significant skin changes that these patients complain about, like a dermatitis and some nail changes as well.
Yeah, I have not seen that, but that is reported. And this is from General Dermatology: acute skin and hair symptoms followed by severe delayed eye complications in subjects using the synthetic opiate MT45. And there's hypothesis that this was from a byproduct in the synthesis of the MT45, or is it simply from the MT45 itself? I believe there's some animal literature that shows dermatitis and other chronic sequelae. And this isn't from a single use. This is from repetitive use, from what I understand. Dr. Sessions, have you seen anything other than that?
Just the reports of hair loss are kind of the main thing I saw that wasn't that was in the user experience that we don't have a slide of here.
Yeah, the alopecia, that's a good comment. So interesting. All right. Are there any other Q&A topics, Dr. Bishovitz, comments that we should address?
None right now, no.
I think we're doing pretty good per time here. Case 2, and this is Dr. Sessions, I'll let you present. So just let me know when to advance. It's a tianeptine abuse and withdrawal in an amateur pharmacologist.
Okay, so this was a 24-year-old male that presented to an emergency department where I was working. His chief complaint was really insomnia. He was diaphoretic. He had really bad myalgias, such that he had received an infectious workup, diarrhea, and he had been seen off and on for GI symptoms for some time. This complaint of lightning pains was kind of his description of his myalgias, and now presented acutely suicidal. And this was his second visit, actually, where he had voiced suicidality. He was initially seen by a physician assistant, but felt to be so acutely ill that they needed to staff him with a physician. So that's kind of how I got involved in his care. He said he had been, after I kind of saw him and felt like he was in acute opioid withdrawal, on questioning, he revealed he'd been taking tianeptine daily for 5 years. He said he'd been getting it from a company in Florida online, which would surprise no one in the US. He said he had escalated from hundreds of milligrams a day up to a total of 20 grams daily for almost the entire 5 years. He had escalated pretty quickly, his dosing. Before he came to the ED, he said he had tried to stop. Then his symptoms got so bad that he went in his garage, he pulled out 18 empty bottles, he scraped together of what he felt to be a 3-gram dose. He took that 3 hours prior to arrival with really no great relief of his symptoms. He said he started using it because he had depression and anxiety that he was trying to treat himself, and that for its nootropic effects, he worked at a medical device company and felt like it would enhance his performance. He also felt it made him better at video games. So we can go to the next slide. He said initially he felt like his work performance and his marriage had improved because of the treatment of his depression and anxiety and the nootropic effect, but rapidly he'd seen a decline in his work and his marriage. He said he had cashed out his 401k to buy tianeptine, and that was kind of the last straw with his significant other. He'd had a lot of visits in our area that we could see through our Care Everywhere system with gastrointestinal symptoms in the last year and a half. That he related to attempted sobriety and withdrawal. He said that he had tried to quit with a tramadol taper. He had obtained tramadol from a well-meaning emergency physician and tried to taper off with that. And then he had been buying large amounts of poppy seed and making poppy seed tea to treat his withdrawal symptoms and trying to taper down with that. Next slide. So in the ED, he was tachycardic. His max heart rate was actually 140, very diaphoretic, just kind of soaking the sheets in the emergency department. very, very anxious, able to voice it, and clearly with the view of his affect, very anxious. On his urine drug screen, interestingly, only positive for barbiturates. His CBC, mild normocytic anemia, nothing an emergency physician or primary care doc would bat an eye at, I don't think. So I guess the questions I have with this presentation for the panelists would be, are you familiar with tianeptine? What is it? What has your experience been with it, if any? And have you seen dependence and withdrawal? And then as we talk about that dependence and withdrawal, if you wanted to comment about his the use of tramadol or the poppy seed tea, I think we can. If Dr. Wiggin, if you'd like to make any comment first, I think we can start there.
Sure, I can recall a patient bringing in a bottle of tianeptine he had ordered as a research chemical, just like this gentleman. He had thought it will enhance his cognition. He thought it is a nootropic. He'd done his own research and found that it is actually used as an antidepressant. It is an atypical tricyclic antidepressant that has, at low doses, some of the effects that are somewhat similar to tricyclic antidepressants. I don't believe it's as anticholinergic or antimuscarinic, but at high doses, it has opioid effects. And this really wasn't discovered until, I think, 2014. So it's interesting that this patient has like a 5-year history of this, but you have to really get very, very high doses. I recently looked at the pharmacology trying to find, a lot of the information in pharmacology. And pharmacology at low doses for drugs can be very different than at high doses, in particular with prolonged heavy use. I've seen intoxication, but I have not seen dependence and withdrawal. And I do have some thoughts about that, but I'll wait for others. I think the self-prescribed treatment was very interesting. The poppy seed tea, poppy seeds are available in bulk. People prior to making poppy seed tea used to order from eBay the dried poppy pods and make shakes and extracts out of the poppy pods, which have the residue of codeine and morphine and other alkaloids. And so he would get an opioid effect from the poppy seeds. And then the tramadol is interesting, I think, really inappropriate to prescribe to treat dependence, in this patient. If anything, I would, this is opioid withdrawal, I'd consider buprenorphine. But this is a drug that has other effects. I'm wondering, is there some serotonin withdrawal or discontinuation or, other effects? So I would look at some other adjunctive agents beside buprenorphine, but I'll let the other panelists comment as well.
Dr. Hopper, did you have any thoughts?
Yeah, it's a very interesting compound. It is approved in many European countries as an atypical antidepressant, relatively short acting. So in those settings, it's dosed typically at least twice a day. My colleague, Mike Weaver, presented on tianeptine at the National ASAM conference last month. And I would say the opioid effects probably occur at around the sort of 3 to 4 gram a day dose, which is, much, much higher than the pharmacologic doses. The tolerance that this patient describes is probably beyond anything reported in the literature. So that's a very, very interesting phenomenon. And so I would expect that whatever withdrawal he would have would be predominantly opioid based, whereas perhaps at a lower dose, you might see some more SSRI related, serotonin related phenomena. So this, I think, is a pretty remarkable case.
I'm surprised there aren't more lab abnormalities, given that he's, diaphoretic, probably has a lot of GI symptoms, maybe diarrhea, leukocytosis. It sounds like he's actually pretty sick.
Dr. Amaduchi, did you have any other thoughts?
Sure, yeah, I think this is a really interesting case. I personally, again, have not seen this, but have read about it. I think, with the headlines of Tiana Reds and how it may be, I think pretty appropriately described as like the new age kratom. So, at a low dose, it probably has some stimulatory effects, and then the higher doses that you get, more of an opioid effect. And so, patients do find workarounds. I see some comments here about how people try and self-detox with loperamide or even cratamin and it's that self. So it makes sense that you're kind of using something else that acts on the mu receptor to detox. What I do find is interesting in this case is that you have a urine drug screen that was positive for barbiturates. I kind of would expected with kind of how sensitive the TCA screens are that it may have been positive for TCAs. So I guess it's important to realize that not only does it have, and I think with the way that the mechanism of action is, unlike your typical TCAs, it has more of an NMDA and AMPA effect. So in an overdose setting, it may not be like your typical antidepressant overdose, but then also depending on how much they take, just to treat it as basically an opioid withdrawal. And I think there was also another question about different opioid adjuncts, you know, like clonidine, gabapentin. Those are some of the things that would come to mind.
Yeah, I think just, we're going to talk more about it. It's interesting, the dose, if you look at the brand names, the Stavelon in France or the Zaza, which is what you see a lot of people use in the Southern US, the brand name, 12.5 milligrams twice a day or 3 times a day, or 25 milligrams or up to 50 milligrams multiple times a day. Very small doses relative to this patient. That 3-gram dose that Dr. Hopper mentioned seems to come up a lot on the patient experience and then in case reports in the literature. I think the tramadol was an interesting thought with the serotonergic effects, and maybe it was, I find the tianeptine users to be like Yankees fans. They tend to know a lot more about this than your typical user, and it seems to be very thoughtful and kind of very into the chemistry of it. So I wonder if that's kind of where he was going with this. We can go to the next slide and talk a little. That'll lead us into that discussion of adjuncts, I think. So the next slide should be. Yeah, so in the ED, he actually was given 0.1 milligrams of clonidine. His heart rate came down a little. He felt a little better, at least subjectively. Still didn't look great. I talked to him extensively that, this was the middle of the night. It had only been 3 hours since his last use, which for any opioid, for me, that would be a very early induction of buprenorphine, but he pretty much appeared to be in florid withdrawal. But there was this question, was this a cessation syndrome of that antidepressant effect as opposed to purely opioid withdrawal? So I elected to do a home induction of buprenorphine with him. And I followed up with him by phone the next morning and over the next several days. He said after an initial 4 milligram dose of the combo buprenorphine naloxone, he had complete resolution of his symptoms, didn't have any more of the anxiety, the gastrointestinal stuff. His suicidality really resolved just with the idea that he was going to be starting treatment. He was actually stable on just 4 milligrams of buprenorphine daily for 6 weeks. He followed up with his primary, who helped him manage it. He tapered to a 2 milligram dose for about a week, and then discontinued it. And all of his primary care visits haven't really referenced it since then. And he hasn't visited an emergency department in 8 months, as opposed to kind of being there multiple times a month for almost 2 years. So seemed to do really well with the buprenorphine initial dosing and taper. So we can go to the next slide. So just a little more on some of the things we touched on with tianeptine. It is an atypical antidepressant. It binds to that SERT that SERT cites similarly to other TCAs, but actually acts to potentiate its action. So it's kind of they don't use that term for it, but it enhances the reuptake of serotonin, kind of the opposite of an SSRI by locking it in that active configuration and enhancing uptake. You can see, like I said, the TCA structure on that side. That mu agonist effect was discovered in 2014, which is kind of interesting because you'll see in some of the data that we reference later that really coincided with that jump in reports to poison control, at least. And I know some of the authors involved with those are on this this webinar today. The real draw of this medication was, Dr. Wiggin referenced it earlier, is kind of the dirty receptor profile of other TCAs. This seemed to be not have that side effect profile while maintaining efficacy. You can still get it in other countries. The name in France was Stavelon at a 12.5 milligram tablet. Not FDA approved here, scheduled in varying, at varying levels, and others, and depending on what state you're in. Pretty decent cost on the illicit market relative to things that aren't full opioid agonists that we typically think of. And then referencing that NPDS report, the big jump in cases once it was found to be a mu opioid agonist, which is kind of what you would expect. Those 9 deaths, like all deaths reported to poison, it's hard to really tease out. Was tianeptine the major player? At least 6 of them had other substances involved. And then these user reports of euphoria and withdrawal, the idea with this tianeptine is, and you'll even see it quoted in scientific papers, is the good thing about this, even though it's a mu opioid receptor agonist, it's an atypical agonist, and we don't see withdrawal symptoms with cessation. That was obviously at therapeutic dosing, and these doses of 3 grams and greater are just massive. And the 20-gram dosing in this patient is obviously what I would consider supermassive. Next slide.
Just want to comment, it's rather remarkable with, most TCAs, and this is a tricyclic by structure, but clearly not a tricyclic by toxicity profile. If you had, 3 grams, 20 grams of amitriptyline, nortriptamine, clomipramine, any doxepin, any of the classic TCAs, you'd have life-threatening fatal overdose. And, so just kind of the structural analogs of tricyclics certainly don't have the same toxicity profile and different pharmacology.
I wonder if that may play into why his TCA screen was negative on multiple visits as well.
I want to also bring up here a question in the Q&A asking how long after the last dose would you normally start the buprenorphine induction?
So a lot of numbers get kicked around because we're typically doing these after, well, in the past, at least heroin, oxycodone, or we're doing a transition from methadone to, medications that we feel like if we know the dosing, we have a pretty good handle on the pharmacokinetics, if not the toxicokinetics. For this gentleman, I said, you're 3 hours out. We can try and get to 12 hours since you're doing better with the clonidine. I had called him at 8 a.m. the next morning, and he had taken the dose at 7 a.m. and his symptoms had completely resolved by 8 a.m. the next morning. So at that point, he would have been almost exactly 12 hours out from his last reported dose. And when he took the 4 milligram dose of buprenorphine, he had no precipitated symptoms and had relief of his withdrawal symptoms. So, at least from an N of 1, 12 hours seems to be an appropriate duration out from a dose of 3 grams.
Yeah, that seems reasonable to me. I think I might have started a slightly lower dose. I typically, if unknown opioid or, a compound like this, I'm not sure if there's some toxicity or other withdrawal that's, in the mix, although it certainly seems like most of his symptoms are opioid withdrawal. I'd start low and then increase maybe a 2 milligram dose. I like the idea of clonidine, and, in the ED, if he's that anxious, maybe benzodiazepine, but I wouldn't send home with a benzodiazepine. And I don't know if you wanted to describe this slide as well, or do you want me to run through this?
I can run through it. I mean, this is some newer, Poison Control Center data with 84 cases of atypical antidepressants, 63 of those being this tianeptine. I don't know if these were the Stavelon or the Zaza tablets, or if this was, like somebody's reported in the chat, heaping tablespoons of RC research chemical that you'll see people refer to online. 65% of these cases reported withdrawal from tianeptine. And as you look over those withdrawal symptoms, you can see that seems like what we would expect from an opioid withdrawal, or even maybe cessation syndrome of a more typical antidepressant. I find it interesting that 20% of them required ICU admit. I don't know if that's because, like my patient, they just appeared so clinically ill or had such vital sign derangement. And interesting that in this series, only one person received buprenorphine. I think it's also interesting that this big jump in cases, like I said, is it really is in that period after we discovered the mu opioid effect.
Right. It's the 20% requiring ICU may also have been a factor of tianeptine is unfamiliar to a lot of EM and medicine providers, and if somebody has the symptoms you're describing, and they have the myoclonic jerks and tremors, and a little bit of reading, suggests maybe it has some TCA effects, maybe not. Then might have been more of a panic rather than did they really need ICU admission, and they have to look at that subset in this case series. But the myoclonic jerks and tremors are interesting, symptoms of the withdrawal, but again, a different non-traditional opioid. So I think we've really discussed this, Dan. Knowing about TN-emptying pharmacology, intoxication withdrawal management would be aimed at what? Any other comments or thoughts regarding intoxication, overdose, withdrawal?
Here's another interesting question from the Q&A. What adjuncts would you use for the lightning-like pain that the patient is experiencing?
Well, I think aside from the lightning-like pain, I think clonidine was good in this guy because he seems so adrenergic. I think also, similarly to and knowing I think Dr. Amaduchi mentioned at some point that the glutamate effects of this one and kind of that excitatory, I think gabapentin for maybe a prolonged withdrawal phase and these complaints of the muscle aches, the significant anxiety this person had, that all kind of would lead me down to maybe doing adjunctive gabapentin. I'm not very enthusiastic about doing that in somebody who I'm also going to be prescribing Suboxone. But I think early on, especially in somebody who's going to be admitted to the hospital, I think it'd be something reasonable to try.
I'm wondering if that's not a serotonin discontinuation effect. And was it really like pain, or was it lightning-like sensation, like the electrical shock sensation that serotonin or serotonin-rapid discontinuation syndrome kind of features?
Yeah, it certainly seemed more of kind of constant myalgias with those lightning, that almost like people describe with like trigeminal neuralgia or something like that, kind of lightning shock sensation. In
this patient, I would, I wonder if, certainly you began treatment with the nootropic effects as well as depression. You may need, another antidepressant that could be started, fairly acutely. I'd allow a little washout period. What other nootropics are people seeing? I would ask this gentleman. He clearly, to research and find TN-emptying. Did he have any other experience with other nootropics, and what might those be?
The only one that I mentioned, in similarly to what we were talking about with Dr. Amaduchi, was phenibut, and only because I've seen that in our area that seems to be very popular. So I asked specifically about that one. He was familiar with it, but denied using it, and didn't report that he had been obtaining any other like SSRIs or anything like that, using them as nootropics. Denied any like herbals or anything else like that.
Are there any other comments or Q&A, Dr. Bishevitz? Okay, thank you.
I'm sorry, just the general question of when to possibly start an antidepressant at this point. And I think you've got to really evaluate this type of patient. Often when you're stopping any kind of medication of abuse, you might see symptoms of depression, but then they might dissipate after fairly quickly. So I think it really depends on evaluating, and is the patient in a safe place, and that kind of thing, and what sort of psychiatric resources you have in the hospital.
Yeah, those are good comments. I'd also, if he's having myoclonic jerks, tremors, I want to make sure that there's nothing else. Does he have serotonin toxicity? I wouldn't want to start, a drug that's serotonergic if there were, other effects and he was having serotonergic toxicity. So those are great comments. A few more questions, not really related to this case particularly, but panelists, have you been involved in or aware of other non-fentanyl novel synthetic opioid outbreaks in recent years? If so, what did they involve? Dr. Amaduchi?
Sure, yeah. Dr. Sessions touched on this a bit, but we recently had a patient who was misusing phenibut. So he was taking it for anxiety and to help enhance what he thought was enhancing his performance at work. And the typical dose that's recommended, again, this is not available in the United States. I believe it hailed from Russia, is about 200 to 300 milligrams, and our patient was taking 4 to 5 grams a day. And so he came into the ER because he had stopped taking it a few days earlier. He didn't like some of the psychiatric side effects he was having from it, but then he presented pretty classically just like a GABA withdrawal. And we ended up, and it was a pretty prolonged course. We ended up using phenobarbital, loading him in the ER, and then having to do so, I think 2 more times on the floor because he was just persistently adrenergic. So that was something that was new to us, just kind of how long lasting it was. Typically with GABA A, we see alcohol and benzos and we get pretty rapid control with phenobarb, but this seemed to be a more prolonged course. And again, a new drug that we're not seeing very often, but it sounds like it's, becoming more popular.
Yeah, we at the ASAM meeting last month, the national conference, had presented on novel benzodiazepines and gabapentinoids and GHB analogs, including phenibut. It's structurally a pentinoid. So not a novel synthetic opioid, but a nootropic people are looking to, and has a very odd withdrawal syndrome at high doses, the GABA B and alpha 2 delta subunit activity like gabapentin and pregabalin. I've seen a couple of those cases, and I think that's increasing in frequency as people are finding phenibut. Some of the advertisements for phenibut as a nootropic and not an opioid are very attractive. Enhance your social presence and increase your become a social butterfly, decrease your anxiety around others, and they're very well put together. So direct marketing to people that may be very vulnerable. But what about opioid outbreaks, non-fentanyl synthetic opioid outbreaks? Dr. Sessions, have you been involved in any of the clusters of other really potent or other novel synthetic opioids?
No, the two, I mean, we've read about some other ones like the U compounds, but the two that I've seen here recently, and again, they're fentanyl analogs, which was, I had a patient report an allergy to alfentanyl after it was discovered as an adulterant in her heroin, and another patient with an allergy listed to, I don't even know if I'm pronouncing it right, ocfentanyl, like OC fentanyl, which I had never heard of. Apparently it was abandoned because it was just so chemically similar to fentanyl that the additional synthetic steps just kind of made it a dead end molecule. But I had a patient report that as an allergy. I'm not sure how they were exposed to it. But those are the only two other ones that I have seen here recently that weren't just, fentanyl on further testing in history.
Yeah, the fentanyl analogs certainly there's a lot of opportunities for additional analogs with just the basic structure. Dr. Hopper?
Yeah, again, we could definitely talk all day about the synthetic, the non-pharmaceutical fentanyl analogs, but I am not aware of the non-synthetic opioids in our area. Michigan did have a little outbreak of bromphene, which is a fentanyl analog, or purple heroin it's called. That occurred maybe about 6 months ago, but at this point, I'm not aware of any non-synthetic opioid outbreaks locally.
Dr. Bishevitz?
I'm not aware of any here in this area either.
There are a lot of, as I mentioned, a lot of opioids. We tend to see individual cases, but there have been some clusters. In particular, isotonitazine, or ISO, is a analog of etonitazine, which is a super potent opioid, about 1,000 times the potency of morphine in animals, but very unpredictable in humans, maybe 60 times the potency of morphine. It's not used in humans because of the unpredictability, but had been intermittently seen on the illicit market. The isotonitazine is about 2.5 times the potency of hydromorphone in humans, and it was identified first in 2018 or 2019. This is the Journal of Addiction Medicine published a article review of 981 fatal overdoses involving synthetic opioids from Cook County, Illinois, and Milwaukee County, Wisconsin, that occurred from January 1st, 2020 to July 31st, 2021. and 40 of these fatal overdoses had isotonitazine identified in the post-mortem analysis, forensic analysis. And you can see the structure of the isotonitazine over to the left, so a very different structure, not benzimidol or phenanthrene or piperazine, but a novel opioid, another class. Most of the isotonitazine overdoses also involved other substances. The fluelprazolam, or a novel synthetic benzodiazepine analog of alprazolam, was the most common. So again, another cluster. There's also been clusters in Ohio of ISO overdoses in the past year. And so this is one to keep an eye out for. I believe, again, a forensic lab would be able to detect this. There are other analogs of the nitazine class. Interestingly, in 2003, a chemist at ATK Thiokol, which is a drug manufacturing company, had been synthesizing this for himself and had a aerosolized preparation that was using throughout work and throughout the day, and it was identified that he was synthesizing this super potent opioid that I don't believe was even controlled or regulated in the United States, at least scheduled. Wasn't available for human use or prescription, but he was identified and in charge of manufacturing a controlled substance. And so it's a very interesting story if you're interested in kind of this forensic synthetic drug case. And I guess I just have a final question. We still have some time for discussion with attendees. We've talked about novel synthetic opioids, non-fentanyl, but there's also an interesting range of adulterants that are identified, often either with the opioids or purposely added, sometimes identified as byproducts or breakdown products, as some of the fentanyl analogs or metabolites have been determined to be. And wondering, what are you seeing in terms of upcoming adulterants? And then I've got a case, if you can identify what is the culprit adulterant. The patient has large ulcers at injection sites and can't stop using cocaine due to sweats, anxiety, tremors, and headaches. He's saying he's got withdrawal after using cocaine, and this only happened previously. This hasn't happened previously in the mainland U.S. It did happen when he was in Puerto Rico. He'd lived in Puerto Rico prior, and now was in Philadelphia, and now has the same thing occurring with the cocaine use that was happening when he was in Puerto Rico. So what is this isn't cocaine. What is the culprit adulterant here? And then again, any other adulterants panelists want to comment on? Dr. Sessions, what do you think? You're muted.
It's interesting to me. I guess the comment that I have is I was practicing in Puerto Rico for a couple months after Hurricane Maria, and I had a couple of IV drug users there who had really horrific skin findings relative to kind of the rest of their presentation. And I wonder if I was seeing xylazine and just being in a more kind of austere environment didn't have the capacity to send off any testing. So that's interesting to me, but I'm not sure if it's the xylazine itself, if they were using this intentionally, because we've seen people use other veterinary drugs to obtain effect, or if it was just the similar chemical profile and that's why it was being used as an adulterant, and I'm not sure.
Yeah, I've heard of intentional use of it separately, and from what I understand, it's increasingly identified in the eastern, northeast, in Philadelphia, parts of New Jersey. I recently had seen a forensic case where xylazine was identified post-mortem from actually 2018, I think. But yeah, xylazine, so from what I understand, the ulcers are because xylazine is similar to clonidine and alpha-2 agonist, and the alpha-2 agonists cause vasoconstriction. They overlap with the alpha-1 receptor, and so if somebody's injecting, you're going to have some extravasation and vasoconstriction, the peripheral blood flow decreases, you have terrible ulcers because of this vasoconstrictive effect. Centrally, it works like clonidine too. So now you have this rebound hypertension, sweating, anxiety. It's like a clonidine discontinuation syndrome. There may be some other effects on xylazine that I'm not considering, but yeah, that would be what I would think that this gentleman is getting. He's getting a speedball in a sense, but not the traditional opioid cocaine. He's using a alpha 2 agonist, a sedative with the cocaine, and now you've got withdrawal and rebound that then leads to return to use. So, any other thoughts on this, Dr. Hopper?
No, this was actually, I'm glad you presented this. This is new information to me. Locally, we had a big outbreak of levamisole contaminated cocaine, and that was my initial thought, but it typically the sweats wouldn't be typical. Anxiety tremor might be.
Yeah, neutropenia, immunosuppression, and then the levamisole skin lesions with cocaine in particular. So that's a good comment. That's just still a very frequent adulterant of cocaine, very high percentage of cocaine seizures, and samples still contain levamisole throughout the world, from what I understand. Dr. Amaducci?
Yeah, I'm really glad that you guys brought this up because it does seem to be very regional. We're experiencing a ton of xylazine in our opioid supply here, and less so the skin effects and the vascular effects, but more so like an alpha 2 overdose. So these patients kind of have like an opioid toxidrome, and they do have an opioid toxidrome because both of the drugs are in there, but then you give them Narcan and you don't get a great response. So similar to what we see with the clonidine, right? It's probably more the stimulation than the actual naloxone that's having the effect. And then I think Dr. Perrone commented in the chat box that, about a third of the opioid deaths in Philadelphia have xylazine, and we've had a string of, over the past 3 weeks, opioid overdose deaths. So xylazine is definitely prevalent here, and, we need to kind of realize that for overdose and withdrawal.
Yeah, that's a great comment. I've spoken with Dr. Perrone about the xylazine they're finding in Philadelphia. Dr. Bishevitz, have you had any cases or other comments regarding this?
Haven't seen xylazine, have seen a lot of levamisole over the years, contaminating cocaine.
Years ago, I had a family do an intervention at a son that had been in Puerto Rico, basically street hustling and using heroin, cocaine, and he knew that he was using xylazine. They brought him back, and I saw him in clinic and treated him with buprenorphine and clonidine because he was having withdrawal, not just from the opioid, but the xylazine and the clonidine. Buprenorphine worked well, although he disappeared after a week. I think was not stable in an outpatient setting. So a little bit about xylazine. It's an adulterant worth knowing because it really took over Puerto Rico. It started as people would add this to samples, from what I understand, and it is widely available as a veterinary anesthetic. So it's often referred to as anesthesia de caballo. Sometimes also un regalito. The dealers would have a sample of the heroin or cocaine and then have a sub-packaged with a little gift free to enhance the effect. And alpha 2 agonist, which would potentiate the opioids and make it stronger, it would also dampen down some of the adrenergic effects of cocaine, so potentially take away some of the side effects, and also cause sedation. Rebound adrenergic symptoms occurred when someone's dependent, and vasoconstriction on injection sites, hence the ulcers, if any extravasation, and so really a dangerous adulterant to the heroin supply that will increase the lethality as well as the infectious and wound complications, in particular for IV drug use. I would assume if somebody's using intranasally, it would also have perforated septum with recurrent use and some other potential complications. I think that was we have some references. There's also references throughout. There seem to be some more comments and questions. And Dr. Bishevitz, you want to see if there's anything that we haven't addressed? We have a couple minutes left. 1 to 2 minutes.
I think we've addressed all the Q&A in the Q&A section, but the chat has a lot of interesting comments, and people are also saying that it's good to look at Reddit too sometimes for stories about drug use and et cetera.
Yeah, Reddit is an interesting platform. I typically will use Airwood or Blue Light Drug Swarm, but Reddit increasingly, I think, has some subgroups that are very interesting and knowledgeable. You need to take certainly comments with a grain of salt, but when looking for information on these novel psychoactives, the users themselves are very knowledgeable often, and amateur pharmacologists or psychonauts, explorers of the conscious. So I typically end with one final thought, and today I've got the poem "My Papa's Waltz" by Theodore Roethke, who lived from 1908 to 1963. This is a very interesting poem. You can interpret this in a couple of different ways. So "My Papa's Waltz: the whiskey on your breath could make a small boy dizzy, but I hung on like death. Such waltzing was not easy. We romped until the pans slid from the kitchen shelf. My mother's countenance could not unfrown itself. The hand that held my wrist was battered on one knuckle. At every step you missed, my right ear scraped a buckle. You beat time on my head with the palm cake hard by dirt, then waltzed me off to bed, still clinging to your shirt." Okay, so thank you all for joining. I want to thank our panelists for attending. Some great discussion. Send your comments on topics and any feedback on presentation. And I encourage everyone to join us the next First Friday Addiction Toxicology Case Conference from ACMT and ASAM is June 4th at 1 p.m. So thank you all for attending, and have a good weekend. Happy Mother's Day if you